The most listened to radio show on the planet. Even the other stations are tuned in too.
HD Radio.
Broadcasting around the world on the World Wide Web. This is
Salma HD Radio.
your number one internet radio station.
In your face, all over the place. We're online 24/7. 24/7. You're listening to the hottest internet station.
Oh yeah, good evening, good evening, good evening, good evening. This is In His Grace and Mercy. I am Pastor Kekana. I am Dr. Kekana. We are on In His Grace and Mercy Enlightenment Corner on Thursday evenings from 7 a.m. till 8 a.m. We are live on Sauma HD Radio. It's www.saumahdradios.co.za. We are also live on our social media platforms on Facebook, on YouTube, on Instagram. The handle is In His Grace and Mercy. It's about to go down. It's about to go down. But before we need to invite God to be part of us. We need to invite God as usual to guide us, to give us the wisdom to educate. Isizwe sakhe. I am Dr. Kekana. I am Pastor Kekana. This is In His Grace and Mercy Enlightenment Corner on Sauma HD Radio. Ngicela nje sibabe nami bazalwane sithandaze mina nje ngifuna ukuthandaza before ngiya very far so that I can focus this power, this wisdom that we're about to share. Today we'll be talking about Alzheimer's disease. We'll be talking about delirium. This we are doing because of the Mental Health Month. We also, in conjunction with the Mental Health Month, we are discussing also breast issues. And last week we were discussing with the breast cancer survivors, and sometime we had a surgeon who was talking to us about breast cancer. So today we are talking mental health. There are many definitions we give things we don't understand. To top it of all, some of the stuff we say kibuloi. But listen, don't hear this from me. I've got expecting a stereo that I'm going to introduce. I'm just warming you up. Babizabanye to dial on www.saumahdradios.co.za. Listen, you can try and see who's behind this million voices, and this person behind this beautiful voice. I present on Sundays during the week. I slag it in with the voice. I'm a presenter. If you want to see who's talking or who's behind this beautiful voice, COVID told us that you must blow your own horn. You can't blow other people's horn. There was COVID going down, so that I'm blowing my own. So if you want to see who's behind this beautiful voice, just do it like other people do. Video streaming, YouTube, Facebook, Instagram. We are live. Also live on Sauma HD Radio. So that we can pray. Dear Lord, this evening we pray and we ask you, Lord, to join us. Mudimu, you have been great, God. You've been the owner, the engineer. most of Lord, the anchor of the wisdom we have, Lord. We cannot go on without you. We cannot go on without thanking you for the wisdom we have. Lord, we pray in the beautiful name, the one and only name, the name above all names, the name of our Lord Jesus Christ. Amen. Good evening, good evening, good evening. Without further ado, we have aspects. You know, there's some couple of issues that happened, and I'm going to repeat what I said last time. The couple of issues that happened that really questioned our ability, that really questioned our knowledge about this mental health. I mean, there's some time ago, the video that went viral as well also motivated this, that I must try and educate you on this platform. I always say N1 Bomba. It's called N1 North. There was a video that went viral. They say that a lady who really looks like a mental health case was was assaulted, saying that the lady was bewitching them. Listen, I don't know much about that lady, but I know what I saw. And what I saw is somebody who's clearly psychotic, who needs help. But then now we resorted to saying Giboloi. So that's one of the reasons that is actually motivating this also. Also, that is mental health. So we might not be talking about psychosis today or delusions, which is something that I want to talk about possibly next week or the week after next, depending on MK team. So good evening, family. I can see you, Fina, the co-host of this show. I can see you, Sis Brenda. I can see you, Abraham. I can see the rest of you that are there joining in from multiple platforms. I can see people who are on YouTube. Thank you very much for joining us. And see people who are on Facebook. Thank you very much. I can also see people who are on Innis Grace and Mercy platform. I can see the ones that are on Matobani, Maporoma, Dikekana. I can see you guys. I can see you, and thank you for coming through. I'm going to let the experts to break down the topic for today, and then later on we'll deal with Q&As if certain things are not clear, if certain things need clarity, or if you need some light to be shared on certain topic. Today I've got a neurologist who trained at Tuks, University of Pretoria. She's going to introduce herself, and I knew her a long time ago. She was doing undergrad. I can tell you, I was looking much more younger and much more vibrant. I was doing undergrad. Now I'm hammering with the salt and pepper look, and you really never know whether I'm your uncle or your father. But anyway, it's okay. Most likely your father. But now I've known her. She came back to school again to specialize. We're there, the same corridors and everything. So she's a neurologist, practices in neurology. She's going to introduce herself. I also have a clinical psychologist, Baatseba Mothoa. I also met her as an intern long time ago. You can see when you meet good friends, the friendship does not just, we don't meet people for a fluke. In our good memory, we go back to where we started. I always ask people, when you're hammering with people that you met 2 weeks ago, where are the ones that you knew, that you grew up with long time ago? You're suspicious if all the time you're hooking up with new friends. Okay, so now I'm going to start with you, Dr. Nchoe, so that you can introduce yourself. And then after introducing yourself, we're now going to talk about Alzheimer's disease and talk about dementia. And people can ask questions. So you're going to just, in summary, that a layman can understand what is Alzheimer's disease, how can you diagnose that, what are the risk factors, is there any treatment, break it down to us as if we've never heard about it, because most of the people that you're talking to have never heard of this. There maybe some of the people, they never knew there's something called Alzheimer's disease. And then from there, we'll talk about dementia later, but just break it down to us, and then Baatseba will come on a psychological perspective. How do we deal with something like that? And then we'll then talk about another. Over to you, ma'am. Thank you again for allowing us to steal your time in your busy schedule. Good evening.
Okay. Thank you, Dr. Kekana. Thank you for inviting me. I'm so happy to be here. I'm Dr. Nchoe. I'm a neurologist. I'm a specialist neurologist in private practice in Rustenburg from Netcare Fencrest Hospital. So I was taken aback when you sent me this topic, and I said, it's these are disorders of cognition, and these are wide and also deep topics. So I hope that I do justice in just summarizing them and hopefully a lot of people understand what they are. So the topic today is Alzheimer's disease and delirium. I'm going to start by just mentioning Alzheimer's disease is a form of dementia. So we've got an umbrella term of dementia, and Alzheimer's disease falls under that. And just important for me to just talk about dementia in general, because we have reversible causes of dementia and irreversible causes of dementia. So dementia, I'm basically talking about disorder of cognition. So there is a deficit in cognition, which is different. So there's a clear deficit from a previous level of function, and this deficit causes impairment in daily function, in work life or in home life. So we have reversible causes, causes that we can treat and hopefully reverse this condition, or at least halt the progression of the disease. Reversible causes include things like your chronic diseases that probably just need to be managed a little bit better: hypothyroidism, HIV, hypertension, and diabetes. Substances such as alcohol being the most common one that we know. Some medications can cause disturbance of cognition, and this can potentially be reversed. This can be reversed. So we've got reversible causes of dementia, and then Alzheimer's disease comes under irreversible causes of dementia, and also there are also many. It is the most common cause of irreversible cause of dementia. It causes about 60 to 80%. It accounts for 60 to 80% of the dementia. So it's quite common dementia, and it is the most popularly known disease. Usually, what is particular about it is that patients don't present. So it is usually the family that pick up that there's a disturbance in cognition. And when I talk about cognition, there are many. This is basically one of the many domains of brain function. We've got memory and learning. We have language disturbance or disturbance of executive function. So Alzheimer's disease usually starts early on with a disturbance of memory. So hardly ever is a self-reported disturbance of memory in actual dementia. So it's usually the family that must pick up that there's a deficit in the memory of the patient. And when they present to us, we often rely a lot on the family to give us the history, because it is a diagnosis that we make based on history. So we normally want quite a detailed history, the family to tell us exactly what it is that is concerning, what the patient's previous level of function was, and what it is now. So when they say that she's forgetful, what exactly? Give us examples of exactly what you mean. We want to know how long it's been going on for. There is a difference between how quickly the disturbance of memory sets on, whether it was over a day or over months or years. We want to know their background history, their medical history. We want to know the medication that the patient is on, or any substances that they may be using. So quite a long consultation that it usually takes, because we spend a lot of time talking about how they came to present in one's office. So after that, we then usually the patient is in denial about it at that stage, especially early on. They have excuses and reasons for why they behave in a certain manner. So then we go on and assess the patient. We assess the patient's cognition. We talk to them. We check how well orientated they are. Do you know where you are, who you are, what time it is, what year it is? And we also listen to the fluency of the language. Do they pause a lot to try to remember a certain word? And we also test their immediate memory. So we would give them 5 words to remember, and then we distract them by doing other activities, and 10 minutes later we ask them what those words are, and oftentimes there is a deficit. They cannot remember. And then we move on to a clinical examination, a neurological examination, just to find out, are there other signs and symptoms? Because like I said, dementia is not only Alzheimer's, so there may be other neurological disorders or neurological signs that I may pick up that may lead me in a certain direction. From there, we go on to investigations involving the brain's blood workup. So we're hoping that this is reversible. So we're targeting the reversible causes. And after excluding those, then the diagnosis. And what is specific about, the diagnosis of Alzheimer's. Alzheimer's, there's usually early on what we call recent memory impairment. So impairment of recent events. They don't remember what happened yesterday or what conversation was had just a few minutes ago. Early on, they still have long-term memory intact. They know where they were born. They know their siblings' names or their parents' names. But then that usually deteriorates later on. What else do I say? Later on, language also disappears. They struggle to understand or express themselves. And executive functions, this is one of the most important things as well, that a person who was able to do the family budget, the person who was responsible for doing the family budget is now unable to do that. The person who was responsible for driving and organizing events. So executive function is usually also quite early on affected. David, I could go on and on and on and on. So if in between there are questions, that will help me to so I can go specifically into the meat of things. But really, so basically that's what Alzheimer's and dementia is. Delirium.
Yeah,
oh, okay, all right.
So thank you. I have one question, and I know that is quite a deep and a long topic. So what I just picked up is that you have somebody who has a neurodegenerative disease. So this is not reversible. So there's something that you can have somebody who just forgets recent things, and it's actually early on start of recent memory loss. They cannot even remember what they just told you just now. They cannot remember what they just had now, and then but they can still remember where they were born. So, there's certain things that they cannot even remember how they got to where they are. So first of all, this person can still be alert. They can be lost and not even know where they are and how they got there. So one, and which is one of the stuff that when somebody finds somebody like that, and then as well, this is age related. So I hear there's a question that was asked, what is the specific age? So this is gradual. So as you grow, you then the risks becomes more, and also the severity of the disease becomes more as you grow. So, and then to a point where you have to use other means to get the patient to remember stuff that they said, so that they don't remember what they need to do, to a way that they have to have a reminder that says they must take medication. It could be audiovisual, it could be more. And we will address the other question is this, before we move to Baatseba, to give it to us the psychological aspect of this. And you see with Alzheimer's, it's deep. It's not something that usually, like you said, it's not something that usually you pick it up just like that. It's a gradual thing that you see, but this is now becoming worse. So now there is now a question of, is it hereditary? Or Hunt is asking, so, and then before we go to Baatseba, what do you say? Can because that if my grandmother has it, is it that assured that I might have it? Am I at the risk? What is the risk? What is the average population risk if there's such? Over to you, Doctor. We're still with you.
Yes, that is a very common question. My mother had Alzheimer's. Will I also have it? So there is that hereditary Alzheimer's disease, but it's only a small percentage. About 1 to 3% of Alzheimer's disease is inherited, and usually would then start earlier. So Alzheimer's disease, usually the age of onset is 65. So when it's inherited, it usually begins early, like in your 40s. But that's really 1 to 3%. Of the population that comes on with hereditary Alzheimer's disease.
And tell me, now we're saying this is a neurodegenerative. It's something that becomes more and more progressive or more and more severe with time. Do you have any treatment modalities that can reverse this condition? Do you have any treatment modality that when one takes, one can go back to the ages when they're still young? Over to you.
So we don't call it it's not reversible. So yeah, so that's why I started there. It's not reversible, but we do have treatment that can modulate. So what we're trying to do is halt the progression of the disease. There is a group of drugs called the anticholinesterase inhibitors that have been found to, in also about 30 to 40% of patients, that they find that it slows down the progression, but you are still going to progress. But when found early, especially, can halt the progression of the disease or slow it down.
Okay. So we know that this, they say there's an inheritance in it. We know that it progresses. We know that the treatment does not reverse. It actually sort of slows down the process. It helps the process because there is also, just to add, there is a bit of theory, but really the causative insult, it's still postulation last time I checked. And also the theory of this sort of the deposit of protein deposit into your nerve that conducts your stimulus to a point where the conduction is not even the same anymore. So that is why some of the people are taking the same treatment that would amplify the nerve stimulus, meaning when somebody's being told something, the drugs will actually try and amplify that, but you will still progress. So that is why you have some people who take their grandparents or their parents to a facility where they'll be able to look after them, because you can imagine that the caring for these people, it's quite tedious. So sometimes when you take them to this, old age home, some people think that you're neglecting your parents and everything. Look, we've got different views as we grow up, but wisdom comes with a very costly price. That to realize that what you used to judge is not as easy as clear cut as that. Because you have somebody who's not aware. Imagine if you forget, you cannot be aware sometimes that you forget, because you would have forgotten anyway. So it will become difficult for you to deal with somebody who does not know that there's something is wrong with them because they forget. So that's a bit of a problem, even more in terms of the management. But from the psychological perspective, point of view, share some light, plug in the holes where a doctor left the space for you to discuss, and then we'll move into the next topic. But by the time we're done, I want them to know, Ulebu says, hey, I missed the symptoms. What did you say the symptoms are? I think when you talk to us, also answer this question in your talk. Over to you, Baatseba.
Good evening, Tovela. I am so sorry. I hope the environment that I'm in is not affecting the audio. Can you hear me? Because I'm trying to connect my audio. You can hear me? Okay.
I can hear you.
Oh, okay. So I almost said Gilagale because you've already covered a lot of aspects to this. Like Doctor was saying, with some, because of it's the disease of the cognition. Me coming in as a psychologist comes in the border. Already the person will struggle. But delirium, we know the person's awareness might be affected, the person's orientation. They might not know where they are. They might not be aware of what is happening. So already we know anything that affects the mind, anyway. So all of us will come in together. That's where I come in. But also the other thing is that when we move to the other side, because there's attention issues, even the other side there's attention issues, but the delirium, it's acute. You okay right now, all of a sudden the symptoms are there, you not making sense. So that's what makes it easier for people with delirium to get attention. But with Alzheimer's or dementia, as Doctor has said, it's difficult because it's gradual, it's over time, it's progressive, it gets worse with time. And also, most of the people by that time human beings are quite resilient. So when a person realizes that they're a bit forgetful, in the initial stages, even themselves, they have a bit of control. You know, they will kind of put in certain strategies without actually knowing that they are improvising. But because in our nature, we have the ability to actually take charge of our lives, then that is why sometimes you'll see it a bit later on. But now I think I want to point out something important. When doctor spoke about the executive functioning, a typical example linked also to what doctor was saying about, you know, people saying for Mothoa, like Kimoloi and all those things. Think about it. With the executive function, the person will be sitting there being able to, I mean, we're looking at self-control, impulsivity. All of a sudden, you cannot control yourself. You cannot control your urges. You cannot plan. A typical example, making tea becomes a problem. The person, you see a person, they will not be able to know how to boil water, how to cook and everything. Or the person is not orientated to time. They wake up in the middle of the night because they are confused. What are you going to do? You're going to open the door and go outside. Sometimes they are not wearing appropriate clothes. So that is when they'll be exposed, because you go out there, all of a sudden you're confused. So those are some of the, but those are severe types. But you can also check, in a sense of you always getting lost. I mean, when it comes to, doctor was talking about the budgeting, there's misuse of money and all those things. So I think by the time people come to me, maybe they would have already seen a doctor, they would have seen a neurologist, then we will know what we're dealing with. But sometimes you find that some of the patients, they would have symptoms of depression, either their mood is low, they're quite irritable. They might start with me, but when I pick up that, because we were taught that we need to exclude medical things and neurological things, I would have just tested, you know, the basic things, the language, the attention concentration, all those domains I would have looked at to refer further. But already at that stage, the main thing would be to involve the family, because for a person to wake up one day and to realize that their life is going to change, the person is going to require the extended family in terms of care instead of, you know, dealing with the situation. There's a sense of grief as well, because you're losing your sense of independence. All of a sudden you're independent, now you have to rely on other people. And also the family, even themselves, they will be the people that comes in that we usually support through the process of how to better take care, you know, of the family member, which things they must put in place in terms of their care.
Thank you so much. There are a couple of questions that came in. Some I'm gonna just let them, I'm gonna let us deal with them right at the better end. But it's getting quite interesting. If you just joined us on Sauma HD Radio, we are talking Alzheimer's disease. We are talking delirium. Alzheimer's disease is one of the commonest form of dementia. So there's dementia as a bigger umbrella, and Alzheimer's is one of the subtypes of dementia, so to speak. So dementia and Alzheimer's are almost the same thing. It's just a big umbrella. There's other diseases but Alzheimer's is the commonest one that you have. I think it answers your question, Khontseng. We are on Sauma HD Radio. Just dial www.saumahdradio.co.za. www.saumahdradios.co.za. We're also live on our video streaming on Facebook, on YouTube. The handle is In His Grace and Mercy. I am Dr. Kekana. I am with a clinical psychologist, a neurologist, who are unpacking these issues for us. I have noted your question, Fina. I've noted your question, Refilo. I've noted your question. I saw the other person ask the question, but I will come back to the questions. And I like the fact that the questions are coming in. Thank you that you are really, really, really taking an initiative to join us to hear what this is about. Now, I want us to discuss delirium, and then we'll wrap up. Quite interesting now with delirium. So we said let's recap. Alzheimer's irreversible, progresses with age. You have a management strategy that will include all those, from nursing perspective to a neurologist to the psychologist and the family member as the whole system of the umbrella of management. And then, so this is, if you know, Ecclesiastes, I'm sorry, I'm a pastor, I gotta talk about the Bible. Ecclesiastes says, for everything there is time. So if you have enough time, you'll possibly get most of the diseases that are age related. We always say, if you live long enough, you will have arterial disease. So the same thing, if you live long enough, you will have neurocognitive dysfunctions or disorders. So this is, now when it comes to Alzheimer's, it's when you're becoming older and older and older. You know, they used to say when you're growing up that when you grow up as an older person, you actually become young. Because now you know, most of those most of the brain cells are not the same anymore. And plus, if you are using hash drinks early in life, you are banning some of them. But anyway, it's a topic for another day. Dr. Nchoe, I want us to take us through in 5 minutes delirium. What are the signs? Can that be treated? What age can one have delirium? Can a person, you know, well, just break it down to us. I've got some couple of questions for you that I want us, and you'll see why this is very important, because if you don't understand what delirium is and dementia is, because then now anyway, that's not nice. Over to you, doctor.
Okay, so Baatseba put it very nicely also when she was speaking. She said the delirious patient is the one that's easily picked up. There's much easier than the dementia one, because that is a sudden switch. So within minutes, within hours, anybody can become delirious. There are so many causes, and reversible as well. So the causes can be alcohol intoxication, can lead you into delirium. Infections can cause you to become delirious. Infections anywhere in your body, or especially meningitis right in the brain. An imbalance of electrolytes can cause delirium. So anybody at any age can become delirious. But one of the risk factors of delirium is the older people. The older people. So a young person having a bladder infection might get away without becoming delirious, but an older person may be susceptible to becoming acutely confused. When we talk about delirium, we're talking about acute confusion. So there's this disorientation, awareness is impaired, the patient is not alert. So yes.
Okay, so we now have the delirium. So delirium, I always say, you have a patient that comes to the hospital, they are fine. It can be any age. For me, I would operate the patient, and then when the patient is recovering from whatever that they're recovering, that I've operated them for, or whatever that they have, they start getting confused, and some people get agitated. They are just not making sense, and it's all of a sudden, right? So that is just all of a sudden thing. The person was fine, they're supposed to recover and go home. They started changing, and there's two types of delirium. It's hyper and hypo. So the hyper one, some of them are delusional. Some of them would then be somebody that is psychotic. You know, they look psychotic and everything. They just not making sense. And some when they have a hypo, when they have delusions, you can find them saying that they're becoming late for work, and they're saying things that has nothing to do with why they're in hospital. I remember I had this other patient who had delirium after I've operated him, which is quite what happens in most cases. So that is electrolyte imbalance. It can be that the person at home was drinking alcohol. Now they're in hospital, they're not drinking alcohol, they're withdrawing, they have delirium. Can be that the person is taking a treatment at home and then it's not managed well, now impaired with whatever that they have in hospital, now they change condition. Could be somebody who has a thyroid disease and they haven't been taking that treatment, they're hyper, and then they're delirious. They could be taking a treatment combination that will then make them delirious. So delirium, it's what you call crazy. Let's say now, and this person just started now. That person might be delirious. So this is a person who, it can be any age. The person was fine and now all of a sudden they changed. The person was fine the day before, they wake up, they've changed. And the people, the treatment or the management of whatever condition that gave them a trigger, because it's a list. If we start the list, we won't finish. It's a long list. So management can last for days, weeks to months to reverse that. You would do all the tests, the electrolytes are fine. You do CT scan is fine. Everything else will be fine, but the person just does not come together. I always say, like you see that this doesn't get together. And then the patient continues. So that can be for long. So now imagine you have somebody who is delirious, who is fighting people, who's saying things that are not coherent, and then this is all of a sudden, even more when they're like that from the dress code, the presentation. It's either you are going to say this person is really a witch or this person is psychotic, while the person needs your help, and what they have is simple transient. I mean, the list is so long that it even goes to an extent of a simple reaction to a drug or a medication that you're taking combined with something. There's this antibiotics that when we give it to you, we tell you mustn't touch alcohol. If you do, people will say you are crazy. And Flagyl. So a lot of people are taking Flagyl. I see people are just taking Flagyl. Is that drug that the pharmacists that are not adhering to the rules of dispensing, they can just give it to you over the counter. And they don't tell you, look, don't drink alcohol. You take alcohol, and then the combination of alcohol and that drug become delirious. That is what I'm saying. That's what we explain. And some people can say, listen, we just found this person wandering in our yard. We don't know where they come from. They don't even know themselves. They're just aggressive. And then you start saying, you explain to yourself that they were saying that by a lawyer. That is what delirium is. So delirium can be from any age. Any age. We usually say that in hospital, you can have a young man who's well, who doesn't even take any drug, who's not any drug, comes in with a femur fracture. And then you go and fix that femur fracture, and they have what we call effect embolism. They become delirious. Now it becomes an all of a sudden thing, and which is what Baatseba said, that is something that is just all of a sudden. In contrast to Alzheimer, where it's something that over time, this thing is becoming worse and we can't take it anymore, then we go and present. And then the long history is taken, when did it start, and all those things. And delirious can be corrected. It is usually mostly corrected because it's an acute thing. It can be completely reversed and the person comes out of whatever treatment that you are giving them. I hope we did justice to this. Manje, I want us to go to the questions. Questions in the box. I am going to start with this Bible right here. Oti, I'm with my grandmother today, whom hasn't seen for a long time. She doesn't recognize me as a grandchild. In fact, she doesn't recognize all of her grandchildren, even people around her. She only recognizes 2 children, even when I explain I'm the first grandchild. From the second son, she says she knows the girl exists. Also, she wants to be accompanied to her home, even though she stays in a house. I'm so sad. I don't know how to deal with the situation. How can I cope with it? Oh, Refire says that. What is this? What can they do? Dr. Nchoe, that's for you.
I thought it's for Baatseba.
That's for you.
I would send it to the psychologist.
Okay. Mothoa, there we go. Well, hold on. Hold on. You were, now you are back. It's okay.
Okay, I think because we're not hearing other symptoms besides the memory issue. So
Yeah.
if there were other symptoms, and we would actually say, go to doctor so that she can give certain medications to help with that. So it sounds like this has actually quite progressed, and it is quite to have like long-standing memory. I mean, that is why it's easy for her to remember. So chances are, before they lived in that particular house, I'm just making an assumption. Chances are there is a home from the past that she remembers. So at this point, she needs to be supervised. At night, they need to make sure that they lock. You always lock. You take away the keys. You make sure that things like the hazardous things that are not accessible. The gate is locked. Whenever she goes somewhere, she is accompanied. It's going to be quite frustrating. So what I would suggest is to make sure that also there's a lot of pictures around, especially of people that she recognizes, so that whenever she gets into those memory lapses, when she sees photos of people that she recognizes, it will come back, because we want her to feel safe. Because when they don't feel safe, the anxiety levels go up. So those kind of things will also help her a lot. And I don't know if they've actually changed the house, renovated it, but you just need to put as much memories in the home as possible. And the other thing is on a day-to-day basis, because you are the external being, you are the one who's aware that she is kind of having the cognitive deficits. It would be better for you to get supportive help, because as time goes by, as she gets worse, you're going to be a bit more frustrated. But on a day-to-day basis, I would suggest that you have conversations, ask her about her past life, because it would bring her joy. So at this moment, it's just all about creating that safe space for her, making sure that she lives a life of dignity, and just engage her on a day-to-day. Because the rest of the things, the more you ask her questions, but I am whoever, it confuses her and it frustrates her. So to make sure that her life gets enriched, just go with the basics, just to keep her alive. And I think on a more social level and on a more psychological level, just to bring more joy and happiness in that space. Yeah.
Okay, thank you so much. Dokotela, this one is for you. Umatapelo More,
Thank
I
you.
hope
Thank
I
you.
pronounced it. I hope I pronounced it very well. Uyabuza ukuthi, is Alzheimer's disease preventable? Should one do to prevent getting it? Over to you.
So Alzheimer's disease specifically is not, there's no certain way of preventing it. But
Yeah.
what we advise is live a healthy lifestyle, lead a happy lifestyle as much as possible. But there's no specific thing that you can do to prevent it. Specifically Alzheimer's disease, I'm not talking about the umbrella dementia.
Yeah. So like healthy lifestyle goes a long way. I just said that those that start early, plastering their brains with hash drinks, you are most likely going to get it. I think we have addressed the difference between. Now there's this question: can you get Alzheimer's and delirium at the same time? Dementia is part of Alzheimer's, so we'll just focus on this too. Can you get this at the same time?
Yes. So delirium, remember, is that acute change in either infection or whether there's a new infection or acute change in electrolytes. So anybody can get delirium. So Alzheimer's patients can get delirium too. In fact, they are also at risk of getting delirium because they don't really have their full cognition. So any slight infection can spark them to become delirious. So yes.
Okay, good. So you can have all of them at the same time. Ooh, Amo or Elroy. I know who Elroy is. So it says Amo. So Amo is asking us this question: what is the commonest cause and risk factors for delirium, and how can it be prevented or managed?
Okay, so I think we've sort of all covered the causes. We said infection, new environment. You spoke about a patient who's just been operated and having fat embolism. So many different causes. How can it be prevented? or rather manage. Management is about finding the cause. And we know that it's reversible. So once you find the cause, you're onto it.
Yeah. So your commonest cause in most cases, young age, somebody who's on drugs, and then all of a sudden they're withheld from them. Somebody who's taking alcohol and they're withheld from them, they start becoming delirious. So now that is why, I don't know if I should say this, but I'm going to say it anyway. It's the truth. That is why when somebody is an alcohol and somebody who's addicted to alcohol, when they get to hospital, we also prescribe TOTS. I'm not saying you must get to the hospital and then get admitted and said that, we prescribe TOTS so that we can give them what they used to get outside, because it makes it difficult to manage somebody who's then having delirious because of alcohol withdrawal. And then we give them what they've been taking, but we give them at a lower dose. And it's not a fancy alcohol, by the way, especially in government. I don't know in our other hospitals. So that is why, so you prevent that person from not having withdrawals. So the commonest in young patients would be somebody who's smoking something and then is withheld, they get confused and they get delirious and they become aggressive. That is why some of these guys who have withdrawals, they have bizarre, you cannot say this is the presentation spectrum. Different folks, they do different things when they're delirious. So what a set condition I wish the government can do more to educate our communities about the disease. I've seen a story of a black lady naked and they thought she was a witch. Isn't it that is an easy explanation that somebody just says somebody is a witch? And while somebody needs your help, so you condemn them even more. So you change the situation, and then if you change the story, no one goes to find the treatment because you already are translating that Kemuloi. Now, even those ones that were just sitting by the corner, not knowing what to do, they start launching bricks on somebody who's sick. Thank you for learning. What kind of psychosocial support do you give to families of a patient who are affected by this disease? Because the stigma attached to someone losing their memory is so high. That is why we end up having cases of people being mistreated and being labeled bad names in the community. We honestly need more sensitization and education around this disease. So what support can be given? And I think this one talks more to you, Baatseba, with your Vuvuzela background. Yeah.
I feel so exposed. My apologies. I'm in the stadium.
Okay. So what support do you give? What support do you give?
Yeah. So the first thing obviously would be psychoeducation, where we are educating, the family, and if possible, if the community and extended families can be part of, the psychoeducation, it will help a lot, because when you know what you're dealing with, you also have the confidence and you no longer sit with the shame, because I think, the whole stigma, you are affected by stigma because you end up self-stigmatizing yourself, because you don't have the confidence, and then you feel ashamed of what is happening. But when you know what is happening, so it's easy for you, to explain it and to also explain it to other people. And if you are surrounded by people who have the sense of Ubuntu, it will also make it easier, for them to better support you. And I mean, in psychotherapy, it's also just helping you through the process as well. Besides that, we also start helping you with the grief process, because sadly, when you see, you have this, you're just caught in between, because you can see the person is declining, but they're still here. So already you're losing them without actually losing them in a physical sense. So to actually observe that, it's quite difficult. So we'll also help you with the grief, and we'll also help you with, supporting you with coping strategies as well. Because unfortunately, when you have a sick a parent, it doesn't mean that other life situations are not happening. So that is where we'll also help you with management. And if you do have to make a decision to put your parents in a care center, it's also a challenge, but getting the right care. There's also a few groups, for Alzheimer's support, but also we have to be aware where in our own communities, it might be a bit difficult to access, those resources. But most of our clinics, there are psychologists available. Also, social workers are available. I mean, now I can only speak for people around Tshwane district because I have worked in the clinics in Tshwane district, and those support systems have also been there. They are available, for the community if should they need to access them.
Thank you so much. And I think we've addressed what Ida Nchoe says, what can reduce the risk of Alzheimer's disease and other dementias. We've addressed that. So let's move right along. We also have another question from Amu. Are there any lifestyle changes or strategies that can help reduce the risk of developing the disease or experiencing Alzheimer? Well, we've just dealt with that as well in terms of the risks and everything, and what one can do to reduce the risks. Healthy lifestyle goes a long way. It goes a really long way. It's most of the stuff that we do to ourselves are what causes all this. But nonetheless, some people are in a situations where they're next to the mines, where they're smelling fumes all the time, and you don't realize that you're in a cloud of smoke because you are in it, and all those things in the long run, the amount of brain function that remains as you grow old becomes bad. So unfortunately, there are certain things that we must, earlier on, in life, preserve what you can preserve, so to speak. And then Nchoe is asking, the weight loss, is the weight loss attached to this diseases? Because the same grandmother she's talking about has lost a lot of weight. So she's also asking about a lot of weight. Now, let me tell you, if you have a WhatsApp, you can also have a WhatsApp number that I didn't give to you. Now I'm realizing that I didn't give you a WhatsApp number that you can actually WhatsApp. You can also WhatsApp once you watch this, because it's going to remain as a podcast. You can still send in a WhatsApp. We'll then forward it to our panelists to be able to answer whenever they have time. So we have a WhatsApp number. You can send a voice note. You can send a WhatsApp. The number is 07638677025. 07638677025. It's Ines, Grace, and Mercy WhatsApp number to ask questions. Weight loss, Dokotela, does a weight loss, contribute to this? I've seen a lot of patients actually that psychotic, some that are mentally ill, they actually lose weight until you put them on treatment. They start gaining back the weight. So the weight loss.
Well, feeding it becomes a problem in these patients. It's difficult for them to cooperate with feeding. So nutrition usually is lacking, and that's what results in weight loss.
Yeah. So there you have it. So you can imagine. Think about the person in the location or all the time, walking by the highway, date and everything. Think about it. When do they actually have time? So also when you have somebody who's an elderly who has Alzheimer's, they forget that they need to eat. Sometimes they become so much busy just going around and talking to themselves that they lose weight. So now the last question from Lebo says, any support systems that government gives towards these diseases that we're talking about today? Any lights?
Well, Baatseba mentioned access to the clinics. I think that's what I picked up. Yeah.
The clinics, it's always good to go to the clinics, because also I think, I'm looking at the lady who's busy asking the questions about the grandmother. It's always good to send the person to the clinic, because they can run the blood test, determine the diagnosis, because now, it's good that she can sort of like take the symptoms and link them. The important thing is to go to the clinic. Primary health care are quite good. There is all the support there. They will do the test, they will diagnose, they will give treatment, yet they will also link the person to a social worker who will check the facilities that are available, the groups that are available. They will link them to the psychologist who is there, so then they will get everything. So the support is there. It's just that at that point, every family or every patient, their situations are unique. So we cannot just say this is the whole, like the whole umbrella for everybody, because we have to look at the circumstances. So it will be easier for them to give them the right treatment. So what I wanted to just say, I think the other thing that we need to change our attitudes towards geriatric wellness. I think at this point it's easy to neglect our elders. It's easy, to not pay attention to them, and even the way we look at them. As she's old or he is old, it could be that. So I think also it has to be, the whole attitude around our elders, how we treat them, how we take care of them, and the services that they receive as well.
Yeah, thank you so much, ladies, today for honoring the invite and coming to actually, educate us like that. We really thank you. So I'm like I'm a cutting shots, we call them, that you can live with us. Bessie Valley. I would like to thank you, from Sauma HD Radio, the powers that be behind all this technology, the MK team, the beautiful team, and would like to thank you from myself as well. I'd like to thank you for the time that you took. Really, I know, the schedules are quite busy. We rock up home late. We have to split the time, the family, ourselves, and work. Yeah, it's quite hectic. I can see you still wearing scrubs, and except Baatseba, we don't have a life. But anyway, parting shots. Let's start with you, Baatseba, and then so that we can, and Dr. Nchoe, then I'm going to call it there.
Okay, thank you very much for this opportunity. I really appreciate it. All I can say is, thank you so much, Doc, for organizing this topic. It's a very important topic for our community. And now I think the message of this topic is people don't have to suffer alone. There are experts out there, that medical doctors, and there also are specialists like Dr. Nchoe who can actually assist, when there is a specific diagnosis that is there, and in terms of offering, treatment. And also there is support, like I said, from a psychological point of view, from the social worker point of view, from community, projects that are able to support the families. They don't have to suffer, continue to suffer on their own. Thank you so much.
Thank you. Dr. Nchoe, over to you. Last parting shots right there. And people are really appreciating the knowledge that you guys imparted today, the knowledge that you gave them, the enlightenment that you gave them. I really appreciate. I feel educated as well myself. Parting shots.
Okay, no, thank you. Thank you so much for hosting this and for bringing this topic to light. I think it's an important enough topic to deserve a meeting like this. I hope that the awareness is out there, that come in, let us diagnose, let us find if it's reversible or not reversible, and help you to cope and see what we can do for you. So yeah, spread the word.
Oh yes, thank you very much. Oh, Baatseba, I think she forgot to say she's found around GP, and then if she shares the details, we'll be able to post them on this broadcast and stuff. But she's found around GP. She's a clinical psychologist. She's also practicing in private. The details, you will find them on this link. They'll share them, I'll post them. Dr. Nchoe, you are in Rustenburg, you said?
Yes, Netcare Fencrest Hospital.
Fencrest, Netcare, right there in Rustenburg. Rusty Dusty, they call it. She's right there. From myself, thank you very much. This is Enlightenment Corner with In His Grace and Mercy and Sauma HD Radio. It's www.saumahdradios.co.za. Would like to thank God, praise God for this. It was really an enlightenment indeed. And this topic is quite serious for us to have this meeting again. So let's meet again, same time, same place. I am Dr. Kekana. I am Pastor Kekana on Enlightenment Corner on Thursday, 7 p.m. till 8 p.m. We are also live on Sauma HD Radio on Sundays from 7 a.m. till 9 a.m., where we preach the word of God. Firing all the cylinders, boy. Firing all the cylinders. Go on, care. We thank God with everything that we have. Profession-wise, anointing-wise, everything. I'm telling you, God is great. Stick with God. Don't stick with men. Stick with the Creator, not the one who's created. And then you will see. Into Zako will just have ukan. Before I go, that I want to do this before I leave. Ithanda imina lento ungawari. Nchoe, this is in His grace and mercy. I am Pastor Kekana. I am Dr. Kekana. Till we meet again on Sauma HD Radio, Santanda Nonke. We'll see you again. Thank you very much.